So today we are going to talk about aspergillosis. Now, the, the idea of aspergillosis is there is a species, the fungal species called Aspergillus, and the spore of Aspergillus species, when someone inhales those spores, it can cause aspergillosis. Now, there are various forms of aspergillosis. So we are going to talk about all of these forms. It include spectrum of disease. Number one is invasive aspergillosis. Number two is allergic bronchopulmonary aspergillosis. And number three is chronic pulmonary aspergillosis. So there are three forms: invasive aspergillosis, allergic bronchopulmonary aspergillosis, and chronic pulmonary aspergillosis. Then there are further three types of chronic pulmonary aspergillosis. We will talk about that once we reach there. Let's talk about invasive aspergillosis. For MRCP purpose, usually for invasive aspergillosis, most of the time the presentation of the patient working in an environment where usually the fungus or the fungal species are usually present, like the forms or barns, they are a bit moisty area, molds can form there easily. So this is the one thing that we will find out in the question of aspergillosis. Someone working in the moist environment, most of the time it is forms, or someone working as a farmer. Invasive aspergillosis, the second thing in the question will be someone is immunocompromised. If someone is immunocompromised, the way aspergillus fungal species interact with the body is invasive pattern. If someone is immunocompetent, the same spore can present as chronic pulmonary aspergillosis, as we will see later. So the way it will work, someone will inhale the spore, obviously there will be formation of hyphae and then interaction between hyphae and macrophages. Obviously the fungal part will take over the macrophages because the person is immunocompromised, and then those hyphae disseminate locally and cause inflammation and thrombosis, and this dissemination can then go to brain, eye, skin, kidney, liver, spleen, anywhere. But mostly, obviously, it can cause symptoms of all these things. But for the exam point of view, mostly we will see the respiratory symptoms are more dominant. The clinical features, the most common that we see usually: pleuritic chest pain, productive cough, fever, and then all the symptoms that someone can have because of they are immunocompromised, maybe the history of cancer, Hodgkin lymphoma, or maybe AML, CML, CLL, weight loss, night sweat, low grade fever. So all these things are there. The most important thing to differentiate, either it is invasive aspergillosis or chronic form, it, in the question it is hemoptysis. Mostly in the question of invasive aspergillosis, hemoptysis will not be present. So far, someone working as a farmer, immunocompromised, coming in with chest pain, productive cough, fever. We will move on. So investigation. So there are multiple ways we can detect this. The positive serum Aspergillus galactomannan is the most important to remember. Positive serum Aspergillus galactomannan. Now, IgG, remember IgG, we also called it as Aspergillus precipitans, will be positive in the chronic form. IgE will be present in ABPA, and in here we can see IgE, but it will not be as prominent. So from investigation point of view, we can remember PCR detection of ribosomal DNA and galactomannan. That is enough. Chest X-ray imaging will show diffuse pulmonary shadowing, non-specific consolidation and cavitation. The CT will show characteristic halo sign. So here is this halo sign on the CT. So the other investigations that we can do is sputum culture and sputum smear. From management point of view, if we are suspecting invasive aspergillosis and the patient is obviously immunocompromised, then we need to start amphotericin B and echinocandin. If someone is suspicious of invasive aspergillosis and high risk, amphotericin B, echinocandin. If someone has confirmed invasive aspergillosis, first of all, we need to do something about the status of being immunocompromised. Whatever we need to do, like colony stimulating factors or plus minus steroids, antifungal. Now, it is a bit tricky. Antifungal, we need to give isavuconazole plus voriconazole. So, this is the combination we usually give for 3 months. Isavuconazole and voriconazole, 3 months. If no improvement, we can switch voriconazole with amphotericin B. So after 3 months of this combination, if there is no improvement, we will change the combination with this plus this. Or we can change to this echinocandin and voriconazole. So it is basically the alternate option. If no improvement with this combination, we can take amphotericin B and voriconazole or echinocandin and isavuconazole. And then there is this posaconazole as prophylaxis if lesions are continuous with great vessels, or if they are involving pericardium, then we can go with some surgical resection. But this is not important for the exam point of view. So now let's make some MCQ related uh, idea for invasive aspergillosis. Someone is coming to you in clinic working as a farmer or working in the barns, getting treatment of something which will make him immunocompromised, AML, CLL, Hodgkin lymphoma, or anything, complaining of low grade fever, chest pain, productive cough, and all those signs of maybe cancer, obviously weight loss, and then there are other non-specific signs of endocarditis, appendicitis, but we don't need to remember. Now the MCQ can be what is the most important investigation, which is Aspergillus galactomannan. This is the most important test. But other tests we can do Aspergillus rust, beta glucagon, and IgE. In imaging, the most important sign is halo sign. CT is obviously the gold standard, and the treatment we can do steroid and antifungal because uh, the combination is usually not very specific. So the questions in the paper, you can see the green section. The questions are not usually from the management as far as invasive aspergillosis is concerned. Chemotherapy, working in barns or farmhouses, immunosuppressed cough, low grade fever. So this is the pattern of MCQ. So that's invasive aspergillosis. Moving on to allergic bronchopulmonary aspergillosis. Now, the idea of allergic bronchopulmonary aspergillosis is sometimes one of the species of Aspergillus fumigatus, which is the species of Aspergillus, they can cause hypersensitivity reaction, usually of type 1 and type 3. And because of these reactions on a longer period of time can cause proximal bronchi to become dilated and bronchiectic. So this is one of the presentation that we can find on the scan. Someone working in the farms, usually the status is not clear if they are immunocompromised or immunocompetent as far as MCQs are concerned, but we can find the scan is showing bronchiectasis or if they have background of bronchiectasis. The other interesting thing is the people with allergic bronchopulmonary aspergillosis from question point of view, allergic asthma, allergic asthma. They have history of asthma, and always asthma is very hard to control. Even if they admit to hospital, they will need the full management until last magnesium sulfate and ipratropium, multiple repeat doses, and maybe admission to hospital. So their asthma is always very severe. Clinical features: asthma type symptom, weight loss, finger clubbing, pleuritic chest pain, V is plus minus brown sputum, no IgG, Aspergillus precipitin negative, and IgE or eosinophilia will be present in bloods. We can see here. Yeah, lab wise IgE and eosinophilia. Now, obviously, clinical features are overlapping. The only thing to remember, someone working in the moist environment has severe asthma coming in with these chest symptom, pleuritic chest pain, asthma symptom, no hemoptysis, and the bloods will show eosinophilia, aspergillosis specific IgE, positive skin flare test for Aspergillus fumigatus. Most of the MCQ, they will ask what is the management. Steroids. To treat acute symptoms, steroid. Now, so there is this MCQ. Poorly controlled asthma, as we discussed, cough, productive, no wheeze, chest X-ray showing opacities, increased IgE specific to Aspergillus fumigatus, no IgG, and what is the management? Steroids. So the only thing we need to take from ABPA, let's see this MCQ. The patient had background of hard to control asthma, increased IgE, no IgG, X-rays showing pram track opacities and ring shadows. What is the management? Steroids. There can be dark brown sputum or eosinophil can be high. The other MCQ: cleaning area, horse riding, stable, recurrent chest infection, dry cough, shortness of breath, no hemoptysis, increased eosinophilia, scattered pulmonary infiltrates. So now we know someone is working in the moist area, chest symptom, eosinophil will be high, and we will go for this option: allergic bronchopulmonary aspergillosis, and management is steroids. And here the management was based on suspicion, and if the status is confirmed, and then antifungal isavuconazole, voriconazole 3 months, otherwise this combination or this combination. Moving on to the third presentation of aspergillosis, which is chronic pulmonary aspergillosis. Usually, if someone is immunocompetent, the fungal species cannot infiltrate quick enough. So that's why they take time, and hence chronic pulmonary aspergillosis. So there are three forms. The number one is Aspergilloma. Number two and three, they are basically the same. So we will talk about that later. Aspergilloma is basically when we inhale the spores of Aspergillus species, and because the person is immunocompetent, they will try to kill those spores and make sure they are confined to same area. Because they are confined to same area, they will appear as a ball on the chest x-ray, and that fungal ball will consist of protein, mucus, tissue debris, infectious cells, and fibrin. So on the chest x-ray we can see here, so it will appear as a ball, and usually the ball is present in upper zone. Now, because this is very localized, patient will be asymptomatic, but if the ball is big enough, patient can have chronic pulmonary aspergillosis symptoms like cough, pleuritic chest pain with hemoptysis, but not always. Hemoptysis is usually the feature of this type of presentation. Chest X-ray will show a round lesion in apex. CT obviously will show the same mobile mass upper lobe with air crescent type shape. Management: if asymptomatic, we don't need to do anything. But if they are symptomatic, we can do surgical resection. We can remove this whole ball because they usually don't respond to antifungal. So the MCQ wise, there were multiple MCQs. Someone is working as a farmer. The X-ray is showing round lesion in the apex, positive Aspergillus precipitans, so positive IgG. Sorry. So what will be the diagnosis? Aspergilloma. Other MCQs: usually the Aspergilloma occur in people who was previously had any cavitating lung disease, tuberculosis. So this was a very different MCQ. The eye presentation of Aspergillus species, usually they can get this ulcerative corneal presentation. If obviously, as we discussed, they can then go to any part of the body: skin, eye, kidney, spleen, and then they cause symptoms there. So now let's quickly recap before we jump on to the last presentation. Someone working as a farmer and getting treatment of some severe cancer, we are thinking of invasive aspergillosis. Someone working as a farmer, background of severe asthma. Right here, we are talking about allergic bronchopulmonary aspergillosis. Someone working as a farmer, the X-ray is showing some mobile mass and round lesion. We are talking about Aspergilloma. Obviously, these two things are not enough to make diagnosis. For invasive aspergillosis, we need maybe more presentation with no hemoptysis of pleuritic chest pain, productive cough, low grade fever. Here, obviously, we can get more or less the same symptom plus minus V's, but allergic bronchopulmonary aspergillosis will show eosinophilia and IgE. Here, the most important investigation is positive serum Aspergillus galactomannan. Aspergilloma is obviously very small, asymptomatic, so the chest X-ray will show round lesion. So let's come to the last. So this is chronic pulmonary aspergillosis, but this C is chronic cavitating pulmonary aspergillosis, and this is chronic necrotizing pulmonary aspergillosis. Necrotizing, and this is cavitating. They both are same at the end of the day, but necrotic form is more quicker and it is more evident in the people who are excessive alcohol abuser. So, cavitating pulmonary aspergillosis can form one or more pulmonary cavities because it is a chronic condition. Necrotizing form is basically quick, associated with COPD and mostly in excessive alcohol abuser. Clinical feature same as before. Now the only difference is hemoptysis. Cough, pleuritic chest pain, weight loss, fatigue, fever, night sweats. So we can see all these symptoms are as of invasive aspergillosis. The only difference is hemoptysis. The other difference is here they will not talk about any treatment of cancer if the patient is taking. Investigation wise, obviously IgG will be high. In ABPA, IgE will be high. And the other word for IgG is Aspergillus precipitans will be high. CT will show multiple cavities and nodules. What is the management? Antifungal to improve symptoms, and the same antifungal we give for invasive aspergillosis. Surgery, we need to remove that lobe, and obviously for hemoptysis we can do bronchial artery embolization for the treatment of hemoptysis. So if I just compare invasive and this chronic side by side, someone working as a farmer, chest pain, fever, and maybe weight loss. Same here, working as a farmer, chest pain, fever. The only difference, someone here will be immunocompromised. Here, someone will be immunocompetent. In invasive aspergillosis, no hemoptysis. Here, hemoptysis. The treatment is same antifungal for 3 months. If surgery, we need lobectomy, and for hemoptysis, bronchial artery embolization. For this, we have seen the MCQ, someone with hard to control asthma, working as a farmer, eosinophilia high, IgG high. What is the management? Steroid. We can give itraconazole, but it is not mainstay. Aspergilloma, someone working as a farmer, X-ray is showing some brown lesion. So this is all about, because it is asymptomatic, we don't treat aspergillosis. And obviously you can see all the green bits. In ABPA, it is mostly the management. And in CP, CCP8 is mainly the diagnosis. Invasive aspergillosis, we can see mainly the investigations, and there are no MCQs usually from the management. Thank you. Let's move on to the next topic.